Good evening, all. Welcome to tonight's meeting. My name is Councillor Natalia Perez, Chair of the Health, Adult Social Care Policy Accountability Committee. Before we start, I have a few housekeeping points, please. This meeting is being live streamed on the Council's YouTube channel. By participating, you are consenting to being recorded. Please, can officers and guests introduce themselves when they first address the committee? And please keep your microphones muted unless you are speaking. As several members weren't able to attend in person due to illness, including myself, I have COVID at the moment. We decided to hold tonight's meeting as an informal remote meeting. So I wanted to thank you all for your flexibility. I know that at the beginning we were scheduled to have a meeting in person. So this option, I think it's good that you've agreed to this option. So thank you very much. Okay, so let's move on to agenda item number 1, apologies for absence. David, have we got any apologies?
Apologies from Councillor Noire. Thank
you very much. And I think we've got apologies for lateness from Councillor Coleman. Agenda item number 2, declarations of interest. Do members have any declarations of interest? Do I see any hands raised? No. Okay, thank you very much. Agenda item number 3, minutes. And if I can draw your attention to page 4 of your agenda pack, we have the minutes of the previous meeting. I wanted to ask members if you agree that the minutes of the meeting held on the 25th of January 2023 are an accurate record. Yes? Okay. Thank you. Agenda item number 4, West London NHS Trust update. So this report from Dr. Hilton, who's here with us this evening, will cover 3 different aspects. One of it is an action log, the other one is on the ailing beds, and there's a third item on the health watch. So the first item is on the action log. So it's actions from previous meetings. Proposal discussed with scrutiny officer to close outstanding items and move some matters onto a work plan long list to be included in future updates to the committee. So we want to just to get an update on some of these actions that have been discussed in the past and what we want to close and what we want to have updates on going forward. Afterwards, we will then have an update on the ailing bed. So Dr. Hilton, over to you.
Thank you very much, Chair, and I hope you are well and get well soon from your COVID. Thank you very much for asking us back to the committee to talk about these items. And although it's a slightly different order to the paper, I think the suggestion was to talk about the outstanding actions first. There are a number of actions that we have collected in the previous presentations that we've given to the committee that have been accruing, and we were very keen in conversation with the scrutiny officer, and I think with yourself through her, to do some spring cleaning of those actions to satisfy the committee's inquiries, but also to move to a position where we can understand a work plan going forwards of other things that the committee would wish to scrutinise. So I've sought in the PAC to respond. I've drawn the attention of the committee to the responses that were appended to our presentation in November, but also answered a number of specific questions that were raised in recent meetings, including around the Trust's recruitment activities. And I've given some information about the growth of West London Trust in the last 12 months, including the number of nursing staff that we are recruiting in our pipeline. The specific question that was asked was around the number of individuals that we recruit directly from colleges and universities. I have struggled, in all honesty, to find a specific answer to that question. because we recruit through a number of different professions and in partnership with a number of universities. But I've provided some narrative that I hope satisfies the inquiries of the committee. And it would also be perhaps appropriate for me to add that we have recently received the feedback from the NHS staff survey, which was published last week. And the Trust is pleased that although the NHS has been going through an incredibly challenging period of time over the last 12 months, West London Trust is the only organisation in Northwest London to be in the top quartile for all domains of the NHS staff survey. And we also compare positively with the other mental health trusts in London, being third using the same measure. So that was the HR question, and I'm happy to pause if you feel individuals would like to ask more or to move on and draw attention to the other answers I've provided.
I'm happy to pause just for a bit to see if members have got any questions in relation to this particular update. Jim, over to you, please. You're muted, yes.
Thanks, Chair. A bit slow there. First of all, Chris, really pleased to find that the local West London Trust is way up in the top quartile, and that's good news for all of us. And I think we're very pleased. My question is about recruiting. I know from the fairly responsible reporting that recruiting staff across the NHS, particularly mental health, is very challenging at the moment. So the fact you managed to recruit a large number of people, I think really is pleasing. But I'd like to follow that up with a couple of questions, because I'm wondering how this might go on performance. You've recruited in a range of domains. What I'd like to ask is, within those domains, given you've successfully recruited, what are the gaps that remain? And the second question, which comes up everywhere at the moment in the public services, and particularly in the NHS, it's a question about staff turnover. Is there a large or small of staff turnover, and how would this impact on team building, on continuity of care for patients? And that is in the context of pretty well done for the recruiting, but is to try to tease out the implications of it.
Thank you, Jim. I'm just trying to pull up the latest figures to satisfy your request. What is certainly the case is, and these are published in our board papers, the most recent of which publicly was earlier this month. We are now at our lowest for over 12 months in terms of vacancy rates across the organisation. And that's, we believe, is due to both a focus on successfully onboarding a number of staff as described in the update here, but also some of the retention initiatives that we have across the organisation, trying to retain the staff that we do have. We've got a number of development leadership programs. I don't have off the top of my head the turnover, but obviously this is monitored on a regular basis and is published within our trust board papers, and I'd be very happy to share them with you, or share the reference at least with you. Yes. Outside the meeting.
Right. Thanks.
Thank you very much, Dr. Hilton. Lucia?
Yes, I second Jim about recruitment, which is really positive. I just did a little tally. I mean, I know that you've recruited, I think it's 198 people over the last 12 months. And I suppose my question was, how many outstanding posts are there still to fill? Given that, certainly the report talks about delays in mental health services. So I just wonder if that's still an area that you're seeking to fill.
Yes, absolutely. Let me just pull up the exact workforce figure. That's the same figures that I was alluding to sharing with Jim, which will give you the the actual number. Clearly, we have ongoing vacancies, and our vacancy rate, our target for the trust, which is reasonably standard across local organisations, is to be less than 14% vacancies across the organisation. As at January, we were at 18.2% vacancies across all disciplines, with nursing vacancies being the highest. That's a 20% vacancy rate. We, in some areas of the organisation, have higher rates than others. Nursing is certainly a pressure across mental health nursing across the whole organisation, and that's why we've had a number of reasonably successful initiatives inviting people in directly from universities, doing the international recruitment campaigns, also developing nursing apprentice and associate roles. So that I hope that answers the question, but there's ongoing work both to get it down to our aspiration of 14, but acknowledging that the rate of 18.2% is the lowest it's been for some time.
Thank you. I would now like to invite Victoria Brignall, please. Victoria.
Yes, hello, hi there. Hi, Christopher. I wanted to ask you, how accessible are mental health services to disabled people in this part of London? For example, do your establishments have changing face toilets, or induction loops? Is information available as well? If you have inpatient units, are there other facilities for PAs to stay with people? Could you have you done a survey of your facilities, and are they accessible to people who are disabled?
Thank you, Victoria. I'm happy to try to answer that question. I think we have done work to ensure that we have some accessibility for all of our services, and we are currently embarking on a specific program to map all of our premises to illustrate the accessibility arrangements for all of them, including step-free access, availability of hearing loops, accessibility of bathrooms, etc. And that work is being led by our Estates and Facilities Department, and will collate all of the accessibility information for all of our services. So I know that it is on our work plan. I don't know the answer to PA support on our inpatient settings, and I think I'm happy to take that away and ask colleagues to explore what arrangements we can put into place for that. Thank you.
As you know, in Hammersmith, Fulham, we are very keen on the idea of co-production. Are disabled people involved in this assessment of your facilities?
I don't know the answer to that, Victoria. I think it's something that we would be very open to. And I know that through mental health settings, we have a scheme every year called the patient-led assessment of the care environment. So we do work with individuals who use our services to assess the care environments that we work from. And I'm certainly sure that our estates and facilities and nursing governance colleagues would welcome disabled participation in that work as well.
Well, could I recommend you get in touch with Access and Disability in Hammersmith, Fulham, because you're helping the council here to pioneer co-production, and we have several people who would be probably available and happy to help with checking that the facilities are up to scratch.
Thank you. I'd welcome that.
Thank you very much, Victoria, for that suggestion. I think it's really good. For us, it's very important element of co-production, and definitely accessibility have been key players in this process. So it's a really good suggestion. Thank you very much. I would now like to invite Keith, please. Keith Mallison. You are muted, Keith.
It's good to see this report, and I thank Chris for it. And I'm pleased that the strong leadership at West London now is resulting in recruitment. But as you know, I'm concerned about the well-being of the workforce, and I'm just wondering if, when a member of staff leaves, whether the trust keeps data on the reasons for leaving, because I think that could inform recruitment methods, in fact, because if it's due to the high cost of living in London, then obviously this is something which would inform us. What I think it would be a very good idea if we could know the reasons, an analysis of the reasons why members of staff feel they have to leave the service. Thanks.
Thanks, Keith. We do report we record and inquire about reasons for leaving, both in terms of the data that individuals give us, but we've also had a recent program of leavers interviews and exit interviews, which has provided some qualitative feedback that informs us about changes that might make us a more attractive employer. I confess we're slightly stepping outside the area of work within the trust that I am responsible for. So I wonder if it might be helpful for me to work with my colleague, who's our Chief People Officer, to provide further information to the committee in future with greater detail. But I can assure you, yes, Keith, we do look at that.
Thank you very much. So, Dr. Hilton, you're updating us on action. So this is in relation to recruitment.
Yeah.
Have we got another question in relation to this update? Councillor Lloyd-Harris?
Get there. Okay, sorry about that. Just on the recruitment, is it possible that we could actually have them included in the reports that we get about the reasons for people leaving? Because it'd be quite useful that we actually had some understanding of what it is. Because I know there are obviously issues, as Keith has said, about London waiting, everything like that. There are also issues regarding career development and also bullying. Now, as we know, in some areas, people are a little loath to sort of say exactly what the reason is, but it might give us a bit of a sense of what is going on if we actually can have that. Even if it's only, say, the top 3 or 5, it would be quite useful.
I'm very happy to include some of this information in future reports on the work plan.
Okay, thank you very much. So from this, the update on this action, you have agreed to email Jim and also Victoria 2 pieces of information. Is that correct?
That's correct.
Great. Thank you very much. And then we've got Councillor Harris' suggestion that we get updates on this in future meetings. Do you want to update us on a different action, please?
I can do so. Continuing on the report, the second request was related to waiting list data following the feedback on the work in our MINT teams, and there was a particular interest around the ethnicity breakdown. And I've shared with you some detail, which remains an incredibly challenged position based on the first time that I reported to this committee about MINT a little over a year ago. According to our systems, we currently have 667 individuals waiting from the Hammersmith and Fulham area for their first appointment to be recorded. And the reason I emphasize the word recorded is we've identified a number of challenges in our electronic patient record systems, which were also identified by the CQC when they inspected us last year, around the discrepancy between where individuals have been seen. They may have had clinical records recorded on the IT systems, but that the appointment is not being correctly what we would refer to as outcomed by the staff member, which does result in some reporting errors. So the numbers that I'm sharing with you are a worst case position. Of the individuals who've been waiting, a significant number appear to have been waiting for more than 90 days. And in response to this, the Trust, through our MINT service teams, have been systematically working through these cases to identify that they have been seen, if they haven't, to expedite their appointments. In terms of the reporting of the data, some of the issue relates to the perpetuation of having 2 recording systems, System 1 and RIA, within the Trust. And we discussed this in the last committee in response to the feedback from the CQC. We have now agreed a plan to simplify this for our community teams, and this is likely to take place over the next few months. I've also provided data for the breakdown of those individuals recorded as not having been seen by the various census categories for their ethnic groups.
Thank you for this update. Do we have any questions from members? Okay, we've got Meryl. Meryl, would you like to ask a question, please?
Yeah. Hi, Chris. I accept that there are probably a lot of problems with recording and so on, but the numbers are extraordinarily high if those are recording problems. And that must be a matter of deep concern that those numbers are still that high. But is it worries me that the aim is to get it down to 28 days, because that's 4 weeks, essentially a month, before patients are being seen anyway. Is there any monitoring going on that actually gives you information about what happens to those patients in that period of time? Because at the moment, and you will know Hafsam's position about this, that we need a more integrated approach to mental health provision. But at the moment, we're looking at community separate from inpatient. But is it the case that some of these people that are being left waiting so long are actually deteriorating and therefore needing more urgent and more acute care?
Yes, so Meryl, we are looking at that, and I welcome your question. I think it's exactly the question that I've been asking in the trust and that other colleagues have been asking in the trust. This is the stabilisation of the MINT transformation is on the trust's level 1 risk register and is subject to an action plan which is related to those CQC action plan that you saw last time. We are aiming to have a 28-day target for the maximum wait for our patients, and these are for patients that are triaged as requiring routine care. Within that, the intention is that there will be individuals who might be triaged as requiring a faster response, and I am able to see that there are individuals who do currently receive a faster response, having been triaged to require one, usually through the unplanned care desks within the MINT services. I think your question about do the patients, whilst waiting, are they at risk of deterioration, is very pertinent, and it's one that we are looking through at individual patient level. We're being supported by a program of work with some external support, mirroring work that we've done with partners in CNWL. Have done similar work next door. Which allows us to look at individuals who reach crisis through our liaison teams, through our crisis assessment and treatment teams, or who require admission, to understand what has been happening to them in the preceding weeks and months, and are they known to the trust? Have they had contact with the trust? Should they have had contact with the trust? And I'd be very happy to share some of the findings of this report once we have a better understanding of what the data is telling us. One of the actions that's followed from this is a dedicated group that's looking at individuals who've accessed crisis services a number of times to see what are we doing, people who've accessed crisis services more, several times in a year, to see what is the deficit in any care planning that might be leading to them reaching crisis a number of times. And that work is progressing and is being chaired by one of my clinical director colleagues.
Sorry for my camera. I think it's my computer's turned it off on me and it won't go back on. But I think it would be useful, Chris, if we could get further reports on this issue, because I think it's a really serious issue, particularly in relation to potential loss of inpatient beds.
I think if we present on MINT at future agendas, we'd be more than welcome to try and incorporate some of this learning into that report.
Thank you.
I share your concern, Meryl. Totally agree in terms of the concern that we have in relation to potential loss of beds. Jim, over to you, please.
Thank you, Chair. Chris, you answered part of my question well, but if I could push it a bit further, when we talk with the CEOs of the acute trusts, they have divided an enormous waiting list into 4 categories: 1, 2, who really do need to be seen very quickly, and 3, 4, where people can, alas, linger on the waiting list for a long period of time without undue deterioration. I'm just wondering, of the groupings who are being triaged, is there a large number of young people there? Does self-harming or suicidal tendencies come in there? And do people wait for a long time? What happens if people quite simply disappear from the waiting list, like you lose contact simply because people lose hope? And they're the people I would worry about a great deal. I mean, this is moving into calms territory, but when I was working in a full-time job, I worked with young people, and I know that self-harming leading to suicidal tendencies and, alas, to people killing themselves, it demanded always a staff who are very attentive. So, and you must be aware of that. I'm just wondering how, at the moment, with a large waiting list, you're dealing with this, and particularly those who go missing, who simply give up, stop responding, or perhaps move elsewhere.
Good points, Jim. I think what I would say is that we are doing our very best to segment the caseload under us, including the waiting list, individuals who've been triaged, into exactly the categories that, well, not quite exactly, but the same principles of the categories that you've described in the acute trusts. Those that require active, regular monitoring and intervention, through a range of other categories, down to individuals whose risk is assessed as being able to perhaps initiate their own follow-up as required. As part of that, we are also monitoring loss to follow-up. And individuals who are lost to follow-up are subject to assertive, effectively an audit of the caseload and actions to determine their engagement in services and to encourage them to engage in services.
Right.
There will be younger people on these lists. The lists I'm describing are the adult services. There's a separate part of the trust looking after children and young people, but this is the adult waiting list. But some of them are younger adults.
Yes. Thanks, Chris.
Thank you, Councillor Lloyd Harris.
Find where I was in the picture. I think Meryl has asked some very good questions, and I think what I was more concerned about is not the loss of beds that we seem to be concerned about. I think it's more the loss of life or the potential. We have a lot of very vulnerable people, and waiting 90 days is just not acceptable. And some of these people will disappear, but that can result in suicide, which obviously we want to try and prevent all of that, clearly. But I'm just wondering, is there any capacity to import experts from other trusts to help address the waiting list?
Could I just ask to clarify your question, Councillor Lloyd Harris? Is that in terms of the expertise that we'd be seeking to import, or the additional capacity to work through the lists? Was that, or both? It's
actually both, because it is a significant problem. I mean, I end up seeing some people that potentially are falling through the cracks from the NHS, which, yeah, can be heartbreaking because they genuinely need help. And I know that there's only so much that you can do. So I'm just wondering whether there's a discussion about how we can actually address that further from maybe other trusts or from other areas we can support the people with help.
I understand the suggestion, and it's certainly something that we do, working in terms of the expertise, working in partnership with other organisations that may be further or more successfully implementing the community mental health framework than we have in West London Trust. So we do work in partnership with those other organisations to try and understand how we can learn from their experience of making the changes that we're trying to do. In terms of bringing in additional capacity, I think that there are limited opportunities for us to do that. We have some examples for common mental illness, for anxiety and depression, where we have worked in partnership with sort of counselling charities, companies providing additional capacity for fixed term periods of time in order to augment the capacity that we have. And there are certainly a number of examples that we've got, similar to how acute trusts might undertake waiting list initiatives where we've done that. But it's certainly, and we've done it in CAMS as well reasonably successfully. But it's certainly something that we found tends to work better for the what's called common mental illness, so the anxiety and depression level, rather than some of the more severe cases that reach us.
Thank you.
I agree with what you're saying, Councillor Harris. I also share your concern in terms of people that sadly may be lost in this process. It's a concern that they're having to wait such a long time. What can be done about it? I'm also concerned about the people that may not be, the groups that may not be monitored. I know from your census, and you alluded to this before as well, in relation to other communities, mixed and multiple ethnic groups, or Black, British, Caribbean, or African communities as well. Is there monitoring as to what impediments are there, what difficulties are there, what barriers are there to access the service? Is there provision in place to potentially address other needs to enable them to access the service if they're not monitored in terms of inequalities as well that we have?
Thank you, Councillor Perez. There's certainly a number of initiatives that we're doing, both through what's called the Ethnicity and Mental Health Improvement Programme, and also some of the work that's been, I think, described with this committee before, undertaken with the borough-based partnership around working in partnership with other organisations, including the voluntary sector, to help us improve our reach and also improve the nature of some of the services that we provide to make them more appropriate for individuals that the Trust may have historically neglected. So I think there is work going on in this space to improve the care we're providing to some of those communities.
Okay, thank you very much. I will invite Lucia and then Linda. Lucia?
Mine's a sort of a continuation of everyone else's question. I think what I'm sort of not hearing or not understanding is the wait time's been about this sort of time for at least the last 12 months. It's not going down. And I know, obviously, you're talking about an operations system which might change. How are you proposing to reduce it down to 28 days? I'm just not hearing how it's going to be reduced. And I mean, I don't know whether the numbers are going up, whether that's another consideration, whether that's changed in the last 12 months. And my other concern is, I know until someone is assessed, it's very difficult to determine their level of need in any event. So, certain people who have reached crisis point might end up in hospital and jump higher up the queue, but for the other people it's incredibly difficult because there's no one actually assessing their level of need, which could be equally as extreme. They just haven't got to that point yet.
Thank you for your question. I think to try and explain the different approaches that we're taking to resolve this problem, and I recognise it is a significant problem, and that's why it's sitting on the Trust's highest rated risk register. First of all, everyone that is coming into the service undergoes a clinical triage. So the clinicians are examining the data that is provided to us by the referrer, by the patient themselves, if they have self-referred, and making an assessment initially of the speed of response that is required. During that process, we're seeking to inform individuals about what to do if something changes, and that includes how to come back to us, how to seek reprioritization, information about the single point of access or some of our other crisis support services. When individuals' needs do change, what we find is that we're using in our planned care teams duty services to address individuals who may present not in a crisis requiring at the point of admission, but whose needs are escalating, to seek that they have some of their needs met. Moving forwards in terms of the recovery of the services, we have seen a stabilization of the caseloads and the referral rates coming into the teams after the new model was implemented. There are, I think, two elements of work that we now need to work through. So the trust has, as I think I've explained previously, combined a number of different functions. So we've combined the assessment service, which I think is the function that you're currently inquiring about, and the speed of the initial assessment. We've combined the recovery teams, which were the long-term support teams, previously known as recovery teams, and then the primary care mental health service, which was a much lower level of service with much higher caseloads that is there to provide advice and support to individuals and to provide advice and support in primary care. One of the things that I think we're now keen to do through the caseload work that I alluded to, I think in response to Jim's point, that separates our caseload into those different cohorts of patients that require more intensive and active monitoring, rather than individuals who might be held on a case list rather than an active caseload, is to ensure that we are prioritizing those that are requiring the most intensive intervention to have the fastest response. So that's the stepwise approach to trying to recover the services that we're doing. Behind that, it all needs to be built into our IT systems. And that's the sort of parallel piece of work that will enable, one, an improvement in reporting, but more importantly, an improvement in the functioning of the teams.
Thank you, Dr. Hilton. And Linda, would like to invite you, please, if you put your hand up.
Thank you. It's a very complex area to look at this, isn't it? Because we're looking at a whole range of things tonight around West London Trust. So there's a conversation we're going to go on to about the beds and the extended consultation on that. We've had conversations about CQC previously and the requirements there, and then the conversation we're having now. I just wonder, Christopher, would it help if, as part of the conversation about the beds, perhaps, because there's a circular argument about a reduction in beds requiring a greater quality of community services as well, or assurance of good quality community services, should I say, not greater quality. Is it worth us looking at this whole assurance of quality as part of the outcome, perhaps, of the consultation of the beds? Just a suggestion, because it does feel like we're going round a bit in circles. I hope that's helpful, Christopher.
I mean, I think, Linda, the suggestion you're making about looking at the quality of the different parts of the patient pathway is welcome, and I certainly think that the strategy for some time has been, of course, to improve the prevention services in order to require fewer crisis and more higher acuity services. So I think the suggestion of looking at whole patient pathways is one that we'd be very open to, and certainly some of the work that we are doing internally that I alluded to before, the flow work looks at the whole pathway. And I guess it links also to work that we really welcome, and I know that Hammersmith and Fulham Council is working in partnership with Hounslow Council and Ealing Council in the work looking at how, as a trust and the three councils that we face, we work together and what differences there are in our pathways. I think that work is really welcome, and we'd be very happy to look at the whole pathway together.
Thank you, Linda, for that suggestion, and thank you, Christopher, for your welcoming that suggestion as well. I think that is helpful. Jim, you've got your hand up.
Yes, it's a different angle on this, Chris. There's a great deal of interesting data crunching coming from the trust, which I think we all welcome very much. And I read with interest, for example, you look at ethnic tables and so forth. That one thing is very hard to avoid, and that's on the national reporting from think tanks and groups like this who are careful with data crunching. It's very clear the ongoing cost of living, the never-ending cost of living crisis, is having an effect on mental health. And that must have an immense weight of demand on trusts like your own. There's one group in particular I'm wondering about. It's an equalities question. I worked in schooling, and I know that if things were bad at home in terms of poverty, that actually affected a youngster. We're talking about adults now, but that invariably fell back on parents as well. The one group of parents who may well be quite vulnerable are single parents who most likely are women. And I'm wondering, in data gathering there, you're actually looking at that equalities aspect of whether the cost of living crisis, the benefits crunches and so forth, are particularly weighing in mental health demand terms on that particular cohort of people, of whom there would be a very great number in the 3 boroughs that you cover.
I'll try to answer that, Jim, but I think I would. The only way I can answer that really is from my own personal clinical experience and when I'm seeing individuals in crisis in the emergency department. And I think that the observations you're making are ones that I definitely recognise. I don't think at the current time that the Trust would be able to report that. I know that in our individual conversations with patients and families, we are exploring, it's routine practice for us to explore the contributing factors to individuals' distress, including their financial well-being, their work status, their access to benefits, their housing status, etc. But I'm not sure, unless other colleagues on the call know, I'm not sure that we record it in an easily reportable way that would allow me to answer your question with a nice graph. Sorry, Jim, you're on mute.
Well, could I come back just very briefly on that? I accept what you're saying, Chris. I'm just wondering, going forward, if you could begin to construct, and it takes some time, and it's obviously rough and ready at the start before finesse is possible. But given that this is something which anecdotally we all recognize, and think tanks do seem to recognize, whether that's something which you could build into recording, even though obviously nobody gets that kind of thing about poverty, about gender right first time.
Sure, I correct myself. I think we do record employment status. So I think there may be some, which is clearly could mean a number of things. But let me take that back, Jim. I recognize it as a contributing factor. My only hesitation is where we put it on the prioritization of things to improve recording of, if that makes sense, because I think we've got some big ticket items that we need to fix the recording of first. But this is an important issue, I completely acknowledge.
Thank you very much. Okay, I would now like to invite Keith, and after that, I'll be keen to move on to the next action, please, because I'm aware that we've got other agenda items this evening.
Thanks very much. Just following on from Jim, I know from my own work with clients, one of the biggest problems I'm finding now, which is affecting mental health, is housing and cost of living. And I've discussed this with Linda and Lisa and housing department. And I'm just wondering if there's any way in which we can get together with housing, social services and West London Trust to find a way in which we can get to grips with this. It's not easy. I know that we've got a hell of a problem in this borough with housing, but it is a big contributory factor. And I think we need to be looking at ways to prevent the onset of mental health rather than when they do present, which is then probably too late.
We're certainly welcome being part of those conversations.
Thank you, Keith. And I think it's important to note as well that the council, as an administration, we are looking at cost of living crisis. So I'm sure there are also conversations that we can have with other departments that will link into this. I know that Councillor Coleman has got his hand that maybe he wants to add on this point as well.
It wasn't on this particular point, Chair. I just want, may I clarify? We're going to moving on to the health watch now. We're going to move on to the beds. I'm not quite sure.
We are first going to moving on to the beds.
Okay. Well, I'll wait. Thanks.
Okay. Thank you. before we go on to the beds, are there other actions that you wanted to update us on?
Rather than drawing specific attention, I hope that the commentary there about our work on suicide and the resources that we work with the third sector that have been commissioned through the ICB, and just to acknowledge there was a request about some must-do actions. There were some should-do actions from the CQC. I presented the must-dos. There were 3 should-dos, and I think all 3 now have been addressed, and that's listed in the PAC. So I think my offer and request to the committee is to hope to close down some of the specific items, although I know we've picked up a couple of additional ones in the conversation today, but then definitely to commit to come back. And I know that the committee is interested in the recovery of the community mental health services, which we're very happy to continue to provide regular updates to the committee on that subject. There were some other topics that may have been appropriate for the work plan at another time that have been raised in previous meetings.
Thank you, Christopher. This is noted, but I think the committee would definitely welcome more regular updates on the CQC should-dos, please. I think it's important to have those updates until you move out of the required improvement assessment.
Yep.
Are members of the committee happy to agree on this? Great. Okay, thank you very much. Okay, now we're going to move on to the item on the Ealing beds. So if I can draw your attention to page, I think it's page 17 of your report, the Ealing beds update, please.
Thank you, Councillor Perez. And I won't repeat what's written in the report or what we discussed in the last meeting, but you had invited me out to provide any update that I could on the work that the Trust has been doing since the end of the enhanced engagement period. And I thought it would be useful to share with the committee what the early observations are and what the Trust has learned in this period. So I think one of the things that we have heard loud and clear, including from London Borough of Hammersmith and Fulham colleagues, and from some of the campaign groups, including HAFSON and their Ealing equivalent, are concerns around the process that the Trust has followed, which was one of enhanced engagement rather than formal public consultation. I think there is a rationale that the Trust had at the time for pursuing that, but we recognise and have apologised we recognise that colleagues feel that is insufficient. One of the questions that we'd be very keen to explore with the committee and with the equivalents in our other boroughs is what additional actions might be required to understand the material differences between what we have done over the last few months and what a full public consultation would entail. And that follows some of the conversations we'd had with chairs of scrutiny committees during the process that led to some additional enhancements and the extension of the period. One of the other things that we've heard very clearly are the concerns of individuals and groups, including partners such as Hammersmith and Fulham, about the potential for loss of service for residents of Ealing in particular, and the impact on the neighbouring boroughs. And I think we, I guess, are keen to understand how we can fully mitigate or how we can mitigate to the best of our ability within the constraints that we have around our estates, those concerns for individuals, including whether that's through transport schemes or whether it is through the provision of other equivalent alternatives. And I guess finally, the thing that we've heard, there are a number of other things that we've heard, but the theme that has been discussed in the earlier part of this presentation around the modelling that has taken place to lead us to believe there is sufficient capacity in the context of understanding the pressures that the system is currently facing is one that I think people clearly have concerns about, and I'm very happy openly to share and discuss those calculations, estimations, but also to work with partners to understand how we can build greater assurance in the work that the Trust is seeking to do. And I know that certainly Linda Jackson and I have been sitting through a number of gold calls recently where we have heard our colleagues in the system discuss the significant pressures that are being faced by the acute trusts for mental health in the last few weeks. Certainly earlier this week, we had 13 or 14 patients at the start of a day waiting in the 3 emergency departments that West London serves. Interestingly, of them, 12 were from out of area for Northwest London. And I think this is a recognition, I think, that there are pressures beyond the Northwest London system, but that do have a knock-on impact. And we're very keen to work as system partners with you all, with the committees and with the local authority and the campaign groups to try and move forward. I know that Councillor Perez, there had been a suggestion of having a further discussion once we have fully done the number crunching and prepared the reports that come inevitably following a period of enhanced engagement. And I really welcome the invitation to meet with the committee to share those ideas and to continue the conversation about how we can move forward within the estate's constraints that we find ourselves in and as an organisation.
Thank you, Mr. Hilton, for this. I note your update and how you've identified some areas of concern that have been raised throughout this period of consultation. I also know that you have responded to the letter that was sent from our strategic director for social care, Lisa Redfern, in relation to the concerns that are being raised for our residents and for Hammersmith and Fulham. I also know that there has been a response to our colleagues from Hudson. As a chair, I think it's important for us to definitely look at this in greater detail and just have one meeting where we focus in this item, an opportunity as well to answer questions to all the concerns that you have already identified, and an opportunity as well to discuss with key partners as well some of those concerns and how you are responding to these. So I would like to suggest that we have an extraordinary meeting before you submit this to your board, which I understand is early May, isn't it? On the 10th of May.
So the original timetable the Trust was working to was to have all of the materials in the public domain for our public board. I think given the feedback that we're receiving, that we can be flexible on that, but we'd be very happy to have the conversation with scrutiny colleagues, both in Hammersmith and Fulham and in the neighbouring boroughs, whether that's separately or collectively, in order to make sure that there has been full opportunity to discuss the findings, the learning, and to think about what additional mitigations we could be exploring for the proposals that the Trust have put forward. So we would be very happy to have that extraordinary meeting at a time that is convenient to the committee.
Okay, thank you so much. So I want to suggest that I think it's Wednesday, the 26th of April, please. And I hope that is a date that's convenient to members of the PAC. Noting as well that there's a time scale for this, and you also have your board meeting in early May. So can we agree to the 26th of April, please, as a date where we come back to this meeting? Dr. Hilton, are you happy with that date?
Yes, I'm happy to commit to that,
Great.
Dr. Perez, if that's a date that is convenient for the committee.
Thank you so much. Now, I also know that other colleagues have got their hands up. So we've got Councillor Lloyd Harris.
It's just a quick one, just a more a clarification. where we talk about having consultations and meetings, I've noticed on page 17, it says these would be convened in Hammersmith and Hounslow, as well as obviously Ealing. That's absolutely fine. But do we mean actually just Hammersmith, or do we mean Hammersmith and Fulham?
Apologies. I think we convened a specific meeting in the London Borough of Hammersmith and Fulham. Okay. And there was a specific venue chosen, but I can't remember which particular venue it was. Perhaps Jim or Merrill would remind me if they were there.
Okay, that's fine. It's just that sometimes Fulham does get sort of left off because there's a huge assumption that doesn't have the issues that the rest of the borough has, which is not accurate. So if that's fine, I don't have a problem. And thanks.
I would now like to invite Councillor Coleman. I know he wanted to speak on this item before. Councillor Coleman.
Oh, well, thank you. Yes, I just wanted to ask if I may, Chris. We had a discussion at the Integrated Care Board, which, as you know, I sit on, and Helen was at the other day with us the other day, and we touched on the issue of bed closures, mental health bed closures, and not just in the West London Trust, but also the Central CNWL, Central North West London, which is planning to shut, which has suspended a large amount of beds at the Gordon Hospital, which is also looking at Butterworth. And it seemed to me, and you refer to in your response, latest letter in response to the council, that there is going to be an integrated mental health care plan for the system. Why, given that this should be integrating, I just want to ask, how well are you working with your counterpart in which covers Westminster, Kensington, Chelsea, and other boroughs? And shouldn't we be waiting for an overarching plan before we go ahead with cutting beds in one borough, which may have an impact on another?
Thanks, Councillor Coleman. Unfortunately, I had to step out of the Integrated Care Board, I think before the mental health item yesterday, but thank you for raising it. We work very collaboratively with CNWL as a neighbouring trust. We're part of a mental health, learning disability and autism evolving provider collaborative, and likewise we collaborate and work in partnership for community health services, including in the community independent service in this borough. So I think we've been doing a significant amount of work together around what was originally the like-minded strategy for North West London and its subsequent evolution. In terms of mental health inpatient beds, we haven't historically shared our inpatient bed base within North West London. We've been operating independently as two organisations and have tended entirely for this population to consume our own smoke. And I think, although there are similar principles to how we have been moving to increased crisis alternatives, etc., in the community, the work that West London had proposed, where we had suspended the 31 beds and re-provided 18, leaving us with that net loss about which we've been engaging, compared with the work with which I'm a lot less familiar, I have to say, in the Westminster area, I think has not been joined up because the two trusts have been working independently on the various estates reconfigurations that we've been left with. In terms of the strategy development, there's the North West London strategy being developed. Within that, there's mental health, sort of a new iteration of that old like-minded strategy, picking up with the long-term plan. I guess to answer your question about should we wait for the strategy before the proposals have been attempted to be taken forward, I think it's a very fair challenge, and I think that one of the two things I would say in response to it are, I think that it's likely that we know the strategy is going to talk about seeking to provide care in the least restrictive settings possible, as close to home as possible, and in individuals' homes through crisis support and alternatives. And I think that it's unlikely to be significantly different from that when the final strategy is developed. And I think from a West London Trust perspective, because the beds had been suspended over 3 years ago now, the internal priority for us is to try to to move forward to a more substantive position around our bed base and to resolve the issue for the individual staff who are technically redeployed for the service. So I think it's been a question around not wishing to prolong a temporary suspension longer than is necessary. But I think it's a fair challenge.
Yeah, thank you. I mean, if I may on that, Chair, I mean, this joining up bit, it is obviously a brave new world, the integrated care system, and we're groping our way towards making it work. And it's new, so it's not one day there wasn't one, and next day there is, and everyone's integrating. I appreciate that, but I'm thinking Butterworth. You know, they're talking in Westminster about cutting Butterworth. Well, that has Hammersmith and Fulham residents in it. So what I don't fully understand, and I know the NHS, when we talk about integrated care, we're as much talking about integrating bits of the NHS with each other as we are about talking about integrating with councils, is when you have Hammersmith and Fulham residents in a Westminster facility, the closing of a facility in Westminster means that the Hammersmith and Fulham residents are going to be requiring support and beds, for want of a better word, elsewhere, and presumably that could end up being provided by the West London Trust. So in that case, if that is the case, you would have a direct interest in their plans, and equally, perhaps some of your plans would have an impact on what happens that CNWL provides. So should you two not be working together much more closely now, particularly as we're going to be expecting that to be the case in an integrated system? You know, you might be saying to them, we don't think it's a great idea you shutting the Butterworth beds. We haven't got any extra beds to offer these Hammersmith and Fulham people.
Councillor Coleman, I think certainly it's our commitment as an organisation to work more collaboratively with CNWL going forwards, and as part of, in the spirit of that, we had our most recent board-to-board meeting last Friday, where a number of these items were explored. I think the Butterworth, again, I'm less familiar with the Butterworth example, except that I know that it's not a CNWL facility currently, and I understand that it provides effectively continuing healthcare for individuals with complex mental health needs and dementia. And the involvement that West London Trust has had has been, as I understand it, that the provider has withdrawn, and as a result of that, we've been asked if there is anything that collectively we can do to support alternative provision for the affected individuals that are in the bed. So you're absolutely right. From a West London Trust perspective, the 3 individuals from Hammersmith and Fulham that were in there, we've been asked, is there anything that we can do, obviously with the consent of the individuals and their families, to support them? West London Trust does deliver a similar facility, which we call the Limes in Southall, but clearly St John's Wood and Southall are very different places, and there's a number of complex conversations to have with individuals in the event that they choose to avail themselves of that offer. But I think the Butterworth is a slightly different patient group, and the fact that there is that cross-border flow is actually was interesting. It was a surprise to me that we had patients, given that the historic relationship that Hammersmith and Fulham has had for spot purchasing beds with West London Trust for that group. But I think your point about collaboration is well made, and certainly we'd be very keen to work collaboratively with CNWL and system partners and the ICB, understanding the impact of changes going forward.
Okay, thank you.
Thank you, Councillor Coleman. Jim Greeley, please.
Thanks, Chair. And I was interested in Chris's answer. Can I say first, I was curious that Amanda's question about Hammersmith and Fulham, that as a long-term Fulhamer, I'm glad to see we have not seceded in any way. And that actually does lead into Ben Coleman's question and to your answer, Chris, because in practice, these areas are very strongly integrated. And I know historically there have been borders which were built up for reasons which were valid a very long time ago, but which have actually much less purchase on social life these days. I think it's good news the two boards actually do meet, but they meet as private boards. One of the interesting things is the drift of work is to actually meet in public, so the public who are actually served by the boards actually see what's going on and feel they've got a stake in how policy is actually developed, rolled out, and is made accountable. And I say that because at the moment, there are two big cross-ICB consultations which really have worked hard to get across the ICB working. One is the orthopedic hub, and that involved people from every borough, from every part of every borough, and a decision in outline has been made, and with lots of suggestions from the public, but it recognized that you couldn't actually pin it down to one place. And the second is end-of-life palliative care, which is still in course. It does seem to me that what the two boards have been asked by the ICB yesterday explicitly, and I think it was accepted by Dr. Penny Dash and by Rob Hurd, that a strategy be brought back to the board sometime in April or May. I think that would be enormously helpful for us, because one of the points which was made is that if decisions are to be made, they need to be made in public in the light of a recognized strategy, which we've only got at the moment as a fragmentary strategy. I think I worked in schooling. It was quite common for people to say live in Fulham, but to go to school in K&C or vice versa, or in Wandsworth and so forth. But across the ICB, I live in Fulham, but I'm a patient in K&C and Gel West. So the two mental health boards working, I think, is just catching up with real life of our local residents, citizens across this area. And I think it would be quite valuable to actually refrain from making long-term decisions right now before we have a strategy. And I worry about one thing, and that's a range of things have been closed temporarily. And I worry that temporary closure simply morphs into permanent. So the word temporary is just pre-permanent. So that is, I think, a danger which we'd like to avoid.
Can I, just to respond, Jim, I think there were 3 points I was just going to make in response. I would very happily take back to the boards of the two trusts that you would be keen for us to meet in public. I can't say I will guess the answer, but I'll certainly take back the request, and I recognise the interest. I think the second point was around, which is a good one made, and you described your experience in education around people and crossing borders. Interestingly, mental health admissions are probably one of the few areas in the NHS where there is considerably less patient choice than in the rest of the NHS. And there are, and I'm not defending that. It's just the way it has evolved, and probably for that reason, it remains the case that the mental health trust responsible for your admission, and therefore the beds or the natural clinical flow into which you'd be admitted, is one that is usually predetermined by your postcode rather than by choice or other factors. And I think it's for that reason that those barriers that you described between the two organisations, and the fact that we tended not to share our bed base, has been the way it has. And I suppose the other thing I'd say is I completely agree with you, Jim, on the danger of temporary suspension leading inevitably to closure. And I think that's one of the reasons why I think the trust has been keen to move forward at the time that we did, with you know, in an open way about our intentions for these buildings, rather than to prolong something temporary, which may have the conclusion that you're describing.
Thank you, Dr. Hilton. I would like to invite Meryl, please, and then Lisa.
Yeah, I also want to follow up. Sorry again about the camera. I can pull faces and no one can see. I want to follow up what Ben said, because there was a statement at the board meeting that there will be a strategy document coming up. But I also want to bring in some points that having received a response from the Trust today to our detailed submission, for which thanks, that there are a number of issues that I think are really quite crucial before any final decisions are made about bed numbers. And they have to do with a whole policy for mental health across Northwest London, because actually your response to us raised a number of other issues that I think people might be concerned about. And that is, for example, all dementia patients who require mental health beds are actually sent out of borough. I didn't know that. And I think that, and other particular mental health needs. And I think that therefore there is a crying need to look at the totality of provision, not just from one trust, but for both trusts across the ICS, because we are now, historically, it wasn't an integrated care system. We are now in a new era. Actually, HAFSON, when we had the joint CCG, tried to ask then for a strategy for mental health. We're only starting to get a positive response now, but I think as we are starting to get a positive response, to ask the Trust to hold back a bit longer till we can see that and assess that in terms of what the needs are across Northwest London is really quite crucial. The other point I would like to make is actually to do with what is quoted in your response to us, that you are building on two papers. One is the NHS long-term plan, which was published in 2019, i.e. pre-pandemic, and things have changed since the pandemic. But the other paper that you are wanting to build on is a paper called Like-Minded, A Case for Change, from Northwest London, NHS, and it's dated 2015. The world's changed since then, and I really do think to base changes on two major documents that are pre-pandemic and pre the current economic situation is really quite worrying. We need to have an updated basis for developing plans. Thanks.
Thank you very much, Meryl. I would also like to suggest that when we come back to this topic on the 26th of April, we also incorporate as part of that conversation the questions that other colleagues like Hafsan may have and the response that you've given to them. I think it's an opportunity for all interested parties to hear the response in relation to all the concerns that have been raised this evening. I would like to invite Lisa, please.
Thank you. I'll be brief because I know we've got another aspect to discuss, the Health Watch report. Thank you, Christopher, for your response, which I received yesterday. I've not had the chance to digest in full yet. I just had a cursory glance at it yesterday, so apologies for that. So I will read it and respond to that. I agree with much as what's been said. If I can follow on from, I agree with what Meryl said around and Councillor Coleman about the need for an integrated approach. We are entering a whole new world, arguably, or that's what we're being told. So I think it is time to sort of have a stand back and reflect on mental health provision in that context. Agree with, I was just touching on what Jim said, the whole business about temporary closures. First of all, several years ago, we had Pembridge. That was not your provision, CLCH's provision for palliative care. That was suspended, temporarily closed, not reopened, only during COVID when we actually as a council pressured health to use them for COVID positive patients. There's Ealing beds, there's the Gordon beds. Again, I know the Gordon beds are to do with CNWL, but I just think, you know, I think it's understandable that this committee have a high degree of scepticism, or certain members do, around beds being temporarily closed or suspended, and then that leads to closure, or you know, years of closure. So I think that was one of my points, the about integration, about temporary closures. I think no one would disagree with the fact, if CQC criticised the beds in Ealing that have been closed, if they were poor quality, no one should have to put up with poor quality. So no one's in disagreement around that. I think I can speak for everyone around that. But that doesn't mean that less beds. And somehow I think the two have been conflated, or certainly that's how it appears. And I think when we have the extraordinary meeting in April, Chair, I think that would be something that we need to unpick a lot more, because it does to me seem they've been conflated. And the other big area is the quality, the necessary quality of community provision. Not that I need to tell you, if we are talking about replacing beds, you know, it requires an awful lot of expertise and an awful lot more input. And I haven't yet, and forgive me if you have sent it or it's been received elsewhere, and I haven't yet seen any financial data or business case or evidence of financial investment around community infrastructure to replace any bedded care. But again, that could be my error, Christopher, and apologise in advance if that's the case. So these are some sort of quite, for me, are central really to the argument, and not just myself, but my staff. I think, again, speaking on, I can't speak on behalf of Hammersmith and Fulham residents, but I think that would be a clear worry, particularly about about all of those things, really. So I'm waffling now, so I will stop, Chair.
May I just respond to say thank you, Lisa, for your letter and the clarity of the specific points that you'd raised, and likewise to Hafson. I suppose as an organisation, we really welcome the challenge around the plans that we're making. I think I absolutely acknowledge the desire to see the wider strategy that this fits within. There are financials, Lisa, I'm happy to draw your attention to them outside the meeting, that demonstrate the changes that we've made and the reinvestment of every penny of revenue in crisis provision. There's absolutely no question that the Trust is seeking to save money, revenue costs from this process. And I guess really I welcome the opportunity for further conversation about how we can work forward through the errors, I guess, that the Trust may have made in the approach that's been taken to this, and we apologise for them, but are keen to think through how we can work with local communities and partner organisations within the constraints that we find ourselves in. And that, particularly from an estate's perspective, is the massive challenge in West London Trust. So I think the bed numbers that we're working on relate to the configurations of beds that we can squeeze safely into the buildings that we think are better, which is why we've ended up with that net reduction, which certainly wasn't the intention of any of this. And we've replaced as much of it as possible, and are keen to explore if there's anything we haven't thought of that might help to mitigate further. So thank you for the feedback, but also for the invitation for a further discussion, Councillor Perez.
Thank you very much, Dr. Hilton, and thank you, Lisa, for your summary and referencing the different points that different people have raised this evening in relation to this item that clearly raises lots of concerns for colleagues in this committee. So can we all agree then that we're going to come back on the 26th of April for an extraordinary meeting to focus on the issue of healing beds. Is that agreed? Okay, thank you very much. Lisa, you're also joining us that day.
Sorry, what did you say?
Lisa, will you be joining us on the 26th as well?
I will. That will probably be my last PAC, actually. Yes.
I'm so sorry to hear that, but well, thank you so much. It's good. It's great to hear that you're joining us for that for that committee.
Yeah.
Thank you, Lisa. Okay. Thank you very much. So please move on to the next item, which is West London NHS Trust Acute Mental Health Services and Health Watch project report. So for this item, I understand that we have other colleagues joining us this evening.
I think Helen may introduce the item and the colleagues that are on the call, because you've heard plenty from me.
Yeah, thank you, Chris. Thank you, Councillor Perez. If I just may briefly introduce this item, which is a joint piece of work between West London Trust Acute Inpatient Services and Health Watch. And just to say a couple of brief words about context and background to the work, I think it was around 18 months ago, we realised we were not getting any material feedback or information about inpatient experience and how people were experiencing inpatient stays, apart from dribs and drabs of family and friends tests, nothing really material. So we had done a piece of work at that time with colleagues in Rethink to engage with service users around crisis care, and we were able to put a specification together as a result of that engagement to actually put in place and commission our crisis cafes, which are now in place. It was a really valuable piece of work, and we wanted to try and replicate that idea of working with a third sector organisation to do the same within our inpatient services. We hadn't done anything like that before. So we put a tender out, and Health Watch were successful in actually coming on board to do the work. So just to emphasise that this work is a particular project. It's outside of the commissioned work that Health Watch normally do. And in terms of the report, the structure of the report is jointly produced. So Health Watch colleagues will talk to us about the methodology and the findings, and colleagues from acute care will talk to us about actions. So I'm just going to invite Carleen from Health Watch and Crystal Ramcharita, who's the head of acute care, along with Dr. Nick Hipkins, I see is here, who may want to say something about the findings. But can I hand over to Carleen in the first instance, just to take us through some of the methodology and some of the findings. Thank you.
Thank you very much, Helen, for the background information. Thank you very much.
Thank you, Helen. Good afternoon, everyone. Afternoon, evening. I'm Carleen Duffy. I'm the Ops Manager for Health Watch Hammersmith and Fulham. I'll give you some background into the project. So from April 2022, Your Voice in Health and Social Care were commissioned to deliver the regular engagement forums to current inpatient service users on both the Hammersmith and Fulham Mental Health Unit and the Lakeside Mental Health Unit on behalf of the Trust. This has been delivered through Health Watch Hammersmith and Fulham. The original plan was for us to do 2 monthly engagement forums on the sites. However, we found that a more effective way of engagement was one-on-one interviews with a staff member or an expert by experience, due to the acutely unwell nature of patients and in general, patients preferring to discuss their experiences one-on-one due to the sensitive and personal nature of their condition. The visits have been taking place monthly over the 4 wards at H&F, and these take place for a duration of 2 hours. We also visit Lakeside 5 wards in the same way. We recruited a large number of experts by experience, all of whom were given background of the project and were provided with mental health training. We've developed a stepped approach into the project with each of these volunteers. Each has been offered debrief exercises and emotional support after the visits. The inclusion of experts by experience into the project, although has been beneficial, has been largely challenging, with many needing to withdraw or take a break for their own mental health due to personal triggers or the highly emotive stories being shared by patients. And this has also been an issue faced by staff. At each of the visits, both staff and experts by experience talk patients through one-on-one interviews, and these cover both qualitative and quantitative questions. How long this takes, the quality and the quantity of the feedback we're receiving varies, largely depending on the capacity of the patient and very often on what stage of the recovery journey they're on. Despite these challenges, Healthwatch H&F consider this to be a really successful engagement project, where almost a year's worth of feedback being collected from inpatients and acute wards. We've managed to amplify feedback and the voice of some of the most vulnerable patients. And we're really pleased with the commitment the Trust has shown in listening to these voices and developing an action plan based on the feedback and the recommendations that we've gathered during these. I'm moving on to how many responses in the findings we've received from H&F. So we have 94 responses from H&F and 113 from Lakeside. Our findings show that both in sentiment and ratings of specific service area, feedback is widely varied between patients being negative, neither negative or positive, but it's a mixed experience across different areas of service delivery. Feedback is explored according to key themes: staff, facilities, surroundings, treatment and care, access to services, medication, continuity and integration of care, and dignity and respect. I'm just going to give a brief overview of some of the summary of the findings, and then we can move on to the action plan that we've worked on together with the NHS. So staff, overall, patients are happy with staff attitude and communication. Most commonly words like helpful, caring, supportive, respectful are used. Communication feedback is more varied, with staff being too busy to hold regular meetings. However, in more recent months, patients feel more positively with how their expectations and their needs are managed. And there's an example that you can see. We've included some of the staff positive comments. Facilities and surroundings, while some patients are really happy with the food they're being provided, more have commented more negatively around food. The majority of patients were happy with the cleanliness. Some stated that the bathrooms can get a bit dirty throughout the day. Patients were happy with the facilities and the spaces that are available to them, but there are some negative comments around the strength of the vapes that are available. Patients felt aware of their diagnosis, I've moved on to treatment and care. Patients are aware of their diagnosis, but they feel that more written and clearer information should be available. We have noticed recently that patients are receiving this. Patients also felt like they prefer more activities. The number of activities that are available have increased during the course of this engagement piece, and this has been visibly noticed by patients. Medication, most patients feel that they're happy with their medication and that their medication has been changed whenever they've made complaints about side effects, and that they always notified of these changes. However, some patients felt that they were unable to retain this information and that written prescriptions and changes would be more helpful. This is another area of improvement that we've observed since the beginning of our engagement, with patients stating they're now receiving written literature of medication and what side effects they can expect. Continuity and integration of care. Some patients expressed limited to no interaction with their community care coordinator at the beginning of the project. There was a common sentiment that the community services needed to be more proactive in their approach. We have seen a noticeable improvement on this, with many patients now stating that they have frequent calls with their care coordinator and weekly visits on the ward. Dignity and respect. Patients feel well respected and taken seriously by staff, particularly around religion. A small number of patients expressed that some conversations could be more confidential. A number of patients have expressed that they would like to be outside more frequently, particularly for smoke breaks. I'll allow Crystal to join me for the action plan.
Thank you, Colleen. Thank you, and good afternoon, everyone. My name is Crystal Ramchart. I'm the Head of Acute Services for Hammersmith and Fulham. So I'm responsible for the inpatient wards within the borough. So thank you. This has been a really invaluable piece of work. It's been a pleasure to work alongside Colleen and her team, coming into our unit, meeting with the patients on a one-to-one, sometimes in groups, and to get that independent feedback to inform and to help us to improve in terms of the standards of care that we provide, and to also meet the needs of the patients that come into our unit. So starting with the first theme, staffing, I think at the start of this project, when I look back at the vacancy rate, we were somewhere sitting around 20% roughly there. And to date, we're now sort of around the 10% mark. Across the unit, in terms of our first level nurses, the band 5 nurses, we have approximately 44 band 5s, and currently we have around 10 vacancies. Now, within those vacancies, we have a number of names that are in the pipeline and in the recruitment process about to start in the next couple of months with us. And in terms of the band 3s, which is our healthcare assistants, we have about 50 posts within our services, and currently we've got under 10 vacancies as well. So significant improvement. And that has been possible through continuous recruitment campaigns, student engagement work with the universities, with Bucks University, with King's, as well as West London Trust, and also events at the Royal College of Nursing. So high level of engagement. We've also introduced other pathways to encourage more junior staff to get onto the nursing career pathway, such as the apprenticeship programs, the nursing associate programs as well, and that's been quite successful. And it's also helped our staff to identify a pathway that they want to work in and a profession that they want to continue to work in as well. And we've also benefited from some of the international recruitment as well. But more importantly, listening to the feedback we've had from our patients around not enough time dedicated to spend with them to do meaningful activities, or even to have more lengthy conversations to talk through what's on their mind at a given point in time. We have looked within the services to redeploy resources when we have had gaps due to unplanned absences. We've also invited our nurse bank partners to join us on a daily basis. So within the unit, we have a unit-wide safety huddle, which starts at 9:30. So any gaps that we identify are immediately looked into, and our nurse bank partners work with us to try and fill those resources. We also have dedicated senior staff present within the unit, and by that I mean matrons who are at a senior level in terms of the banding. There are band 8 nurses, and we have operational managers present. We also draw on the skill mix and the expertise within the MDT to help us to support employees and patients. So where we are short again, we would call more so than we did previously, a safety huddle, so that all resources and all expertise within a given department meets and talk to what are the key priorities for that given shift, what are the main tasks that we need to follow through on, and identify time that we are able to spend with patients on a one-to-one or groups. And so those are some of the actions that we've put in place around our staffing. And it's good to hear that the feedback from our patients also reflects that that piece of work and the improvement there. Moving on to, are there any questions? Councillor Lloyd Harris, hello.
I've just got a couple. Is that all right?
Yeah, I was hoping that we could finish the presentation and then move on to questions.
No, I'm happy to wait then, that's fine.
Yeah.
Okay.
Thank you.
Thank you.
Thank you very much, Crystal. Please carry on.
Yeah, thank you. Again, moving on to facilities and surroundings, it was noted by the patients that some of our hygiene facilities, the toilets, the showers, were not as clean as one would be expected. We work closely with the facilities team, and we have identified dedicated cleaning teams for each of our wards. In addition to that, we also have in place what we call spot checks. So the shift leads, the ward managers and our matrons would carry out daily checks around those facilities, working closely again to ensure that the standards of care provided is what's being implemented. We also have weekly community meetings with our patients. So again, we hear directly from the patient group, and I myself as an operational manager is very present in the unit and will also carry out inspections and also speak to patients on a one-to-one to get their feedback in terms of how things are improving. With regards to the food and provision of food, what the Trust has in place is a working group at a much more organisational level, and we're very much involved in that, and patients are also involved in that. So for us to consider carefully the nutritional needs of our patients, that group consists of dietitians, speech and language therapies, clinical staff such as nursing staff, and facility staff, working closely to look at what the requirements are for our patients, not just in terms of the type of diet, but also considering the individual needs around their fate as well. So we have currently diets such as a modified texture diet, we have salads, we have sandwiches that we provide. We also have a variety of snack boxes so the patient can choose what they want in that particular snack box for a given day. We provide vegan dishes as well and allergy-free diets as well for our patients. When we are reviewing our menus, which is provided on a weekly basis, we also have taster sessions. So patients are invited into those sessions to taste the meals that are going to be provided, and their feedback again is also very important in terms of the quality, the flavour, the portion size, and these are the areas that are carefully considered. Moving on to treatment and care, again there was lots of feedback around lack of information, or information not being given in a timely manner to our patients, and they're not fully understanding their diagnosis. And it's really important, if we're providing care and treatment, that we help our patients to understand the type of treatment we're providing as well as the care that we're providing. What we have currently across the unit, and I've seen this for myself, we have information leaflets around the different types of medication, whether it's an antipsychotic, and that particular sheet where it is representing an antipsychotic, for example, will talk through why the patient is on that medication, the benefits of being on that medication, as well as the side effects. The patient is also given that sheet take away so that they can read that in their own time again and come back to the clinical team should they have any further questions. And again, patients are reviewed in a very timely manner a couple of times during a given week. So that conversation, the consultant also takes place again in terms of checking in with the patient about their medication. Particularly important as well when we're adjusting medication in terms of reducing medication or titrating medication and looking at medication optimization as well. And again, the feedback has been quite positive around that. When patients come into our unit, we also give what we call a welcome pack, and in that pack it explains to the patient, tells the patient about what our unit consists of, what types of treatments and therapies they will be offered within our services. It also gives a sense of the skill mix that we have within a given team so that they know what type of professionals will be involved in their particular care. We also acknowledge that at this point of admission, most of our patients are very unwell, and it may not be the right time or the best time to be engaging around complex conversations around medication. So it's also very important that we work alongside that journey whilst they're in with us to ensure that they are kept informed and that they understand the information provided. Alongside the provision of information, we also work very closely with advocacy. So we do have advocates available for our patients, and we ensure that they have the contact information and details and that they are offered an advocate should that be required as well. In terms of upskilling our staff around treatment and medication, there's a lot of training that we offer within the unit. And we draw again on the expertise of our pharmacists, of our psychologists within the services and our OTs to look at helping our staff to better understand some of the medication that's being used. So should a patient approach any of our staff, they're able to share that information and share it accurately. In terms of accessing services, Now, I did discuss this with Colleen because we wanted to better understand what exactly our patients were asking, and was this in terms of whilst they were with us as an inpatient, or was this in terms of follow-up care post-admission onto community services. And what we have worked diligently with our community partners to ensure is that during that inpatient stay, that the community services are involved very early on. So within 24 to 48 hours, we identify whether a care coordinator, for example, needs to be involved in that service, and that link is initiated and maintained throughout the stay. But also, well before the discharge date, we again identify, do patients require longer term psychological therapy, for example? Can we put them in touch with IAP services or other community services, for example, substance misuse as well? And those links are also initiated whilst you're an inpatient to ensure that it continues within the community setting. In terms of dignity and respect, we also did a lot of work drawing on board resources such as our practice development nurses to work with our teams across the unit, and also human resources to look at specific care around compassion, kindness in action, and also things like maintaining confidentiality as well, in terms of what types of conversation we are having with patients, considering the environment at that point in time. Can that conversation take place in the patient's bedroom where it's much more private, or is there another room that you can take that patient to? So being much more self-aware and much more mindful around conversations where and when they're happening as well. I think linked with dignity and respect as well is the issue around smoking. And we are aware that the trust is a no smoking NHS trust. However, most of our patients coming into our services have been smokers and have been smokers for many years. They're likely to be with us for a short period. So how can we support them in terms of meeting that need safely whilst they're with us? And what we were informed is that there were a number of patients who possibly were hiding cigarettes out in bushes nearby and sort of digging in the dirt to conceal their cigarettes. And of course, it's not dignified at all. And it saddened us when we got that feedback. So we worked together with our smoking cessation team and the trust to see how best can we look at patients still having access to cigarettes, and that being done in a very safe way, but at the same time providing patients with health education, health promotion information, so that they can make informed decisions about their personal choices. We currently have a task and finish group that's in place that's looking at developing a standing operating policy, whereby we will be considering implementing lockers, which will then support patients in being able to safely store lighters and cigarettes, at the same time have access to those. This will be risk assessed and preventing our patients from having to conceal items such as cigarettes out in the community. I think it's also important to say around dignity and respect is ensuring that when patients come into our services, that they understand what it means to be informal, they understand what it means to be detained under the Mental Health Act, and that they are fully aware of their rights under the Act, so that information again is provided to them as early as possible. And where we have patients who at the very start of the admission process is too unwell to retain that information, that is continuously revisited. One way of checking that these things are happening and being able to evidence them is on our REO system, which is our patient medical record system. And again, we have matrons and other leads within the services who will carry out audits. And I myself also, occasionally dip in and check the notes to see, what is the quality of the conversations that are happening, be it by the medical team or other members of the team. Are patients receiving the information that we say we should be giving them? So that is continuously checked.
Thank you so much, Crystal. I appreciate the very thorough and comprehensive report. It's really good. Is it okay if we give you 5 more minutes and then we move on to questions? 5 more minutes enough? Sufficient?
Yeah, I think as Colleen mentioned at the very start as well, for us as a trust and as a unit, it was really helpful, particularly the qualitative data that we obtained from the patients, getting that direct feedback about their experience of the services that we provide. It was well received by the employees across the unit. We don't often, get the opportunity to have this independent and very objective to a degree scrutiny over our services, so we really welcome that. There were some challenges in terms of us having to work with fluctuating levels of acuity across the unit at times, but again, HealthWatch was very flexible in that their approach, working with us and revisiting time and time again to ensure that they were able to get full engagement with pretty much the majority of our patients across the unit. Yes, I think that's my summary.
Thank you so much, Crystal. That's very thorough. Thank you very much to Carleen and to Crystal for the report. I definitely, welcome that this activity has taken place. Is definitely amplifying the voices of the patients, of the residents, that are so important. And I definitely welcome how for each theme that you've addressed, there are observations, and also there are also recommendations which give us a specific guidance as to how to improve some areas of concern, which of course we need to address. Thank you very much. I would now like to invite questions, Councillor Lloyd Harris, and then Jean Greeley, please.
Thank you very much. I have to say, I think it's a very impressive report. I enjoyed reading parts of it. I was slightly horrified about some parts, but there seems to be a plan in place to address the areas of concern. I was just wondering, did anybody consider, when they were asking for volunteers to go in and be with patients, to interview them, to be sort of sit with them in a way and go through this information, did anybody consider that this might in fact trigger off their own issues? And as a follow-up to that, once that was sort of realised, there were moments that were triggered for some people. Were they given ongoing support afterwards in order to deal with it? That's that question. Do you want the other question, or just, which is very quick, or do you just want to take them? Okay. The other one was when we talk about activities, which I think is very important, because otherwise you've got people that are just sitting around the whole day. They're not active. And I mean, there are varying degrees of what that looks like. So I'm just wondering whether you're going to consider any of the activities that are actually physical.
Okay, thank you, Councillor Lloyd Harris.
Yeah, that's it. Thank you.
Okay, I'll invite Colleen to join as well in some of these responses, but certainly with reference to your first question, once we had agreed as a trust that HealthWatch would be working with us, it was really important for us to communicate this information to our patients and to help them to understand the rationale behind why HealthWatch was coming in. We also involved the multidisciplinary team, so very key to this was the psychologists within our services and across the teams working with us and with our patients in preparing them for this piece of work. And again, I think it is fair to say that Colleen's team was able to communicate back to us. And again, in our planning meetings before we had embarked in this work, we had considered very carefully, should there be situations where patients were upset, or as you quite rightly say, it took them back to a place where it was quite personal and they needed some additional support, that we would have contingencies in place to address that. So HealthWatch would be reporting back.
Can I just correct you there? I may have misread the report. I got the impression that the people who were actually going in and interviewing the patients were the ones that had their history triggered by events in that session, not actually the patient themselves.
I mean, I think both would be accurate, and we mitigated for both circumstances, in that we had handovers and handoffs before we would talk to any patients. But in regards to the experts by experience, I always spoke to them before they went in and then debriefed with them afterwards. But they were well aware of the what the project was, and before we took anyone on as an expert by experience, we asked them what their potential triggers would be, so that when we were there, I could look out for it. And then when I would read through it during the debrief, I would check for that, and we would have that conversation.
Thank you.
Shall I continue?
The second part of the question?
Yes, please.
Was about the activities, about whether that included physical activities.
Yeah, so I have two programs in front of me which specifies the OT programs across the unit. So we have a combination of physical activity which happens within the unit. We also have spaces such as external terraces. So we have games such as basketball, football, table tennis. We also have a gym which is based on the ground floor, and patients do have access. All of these activities again are risk assessed. So that happens within the unit. We have a number of board games as well, music activities, dance therapy as well within the services. And externally, our occupational therapist works closely with the patient group to have walking groups, cafe groups, also visiting local facilities such as parks and gardens, etc. And again, the patients are very much involved in this, so we get feedback on a regular basis in terms of what they enjoy and what they would like, and we work, to try and keep this program quite fluid, so that they enjoy what we offer as well. Yeah.
Thank you.
Okay.
Thank you, Crystal. Jim, please.
Yeah, thank you, Chair. This is a very interesting report, which I read through several times, and Amanda's right. There are parts of this which really are very, very good and strong and positive, and other parts which actually did worry me a great deal. I've never worked in mental health, but I spent much of my life working in the public sector, so it really is good to find positive comments from the client group, and I thought that's part I went back and reread and enjoyed. But I was worried because there's an unmissable disjunction between the report, if you'll forgive me putting it like this, and the way Crystal has enunciated things, because the report is highly complex. And from Crystal, I had the impression everything is now working very well. And it doesn't seem to me probable, on the basis of the observation made, that that can possibly be the case. That would mean you'd turned around something at such an extent that everything was now working perfectly. Rather than, I think, describing what we have and what we do, you need an evaluation of what you have works and what doesn't, and what you do, where it's successful and where it actually does need beefing up in some way. Two things in particular, let me hone in for a second. Looking at the very positive comments, there are also comments from patients, which I did find interesting, about the absence of staff, the lack of staff, unplanned absence, and so forth. Now, that's a recurrent drumbeat in the report. And I'm wondering, can somebody, this is the first part, can they account as to why unplanned absence or unavailability of staff happens? Because there it would appear either there was poor resource management, or staff are worn out, or they leave or something. But the absence of people, unless it's factually entirely untrue, what unlikely, I think needs comment. The second one is actually quite interesting because it goes back to an earlier theme from the CQC, and this body did talk about it. It's the continuity and integration of care. I noticed there that some patients really were very pleased with continuity, but the word is many patients were not pleased. They didn't have it. And I noticed in the commentary, and I may sound like an old English teacher here, is that in the commentary, every verb, every adverb is in the conditional tense. It's what ideally might happen, what would happen, what could happen, but not what happens. And I think when we spoke about this last time, because the CQC did focus on this, I think far more nuance is needed. One would like it to be this way, but for a variety of reasons, at this point, it surely cannot be this way, else the report would be a different kind of report. So I think going forward, where community care, to which we're all committed, it's how those gaps are happening, what the reasons for that are happening, so that the word many, which doesn't say a few, it says many, need to be addressed. And I think being much more upfront about not just what works well, and obviously many things do work well, but on key things which don't work well, to ask oneself a self-critical question as to why they don't work and how they might be addressed over a period of time, what the factors are. I think that would be very helpful. Thanks.
Thanks, Jim, for your comments. They're really helpful. So sorry, I didn't know whether I was on mute or not. There is a specific question about the volume of unplanned care that I wonder if Crystal just wants to respond to.
Yeah, thank you, Mr. Greeley. I believe it's around unplanned absences. Is that correct?
It's about unavailability of staff, unplanned absence, nobody to make decisions. It's a set of negatives which goes through from page 27 to page 31, halfway down. And it would be boring and pedantic to track them through. So it's to say that's a theme which is obviously needs to be addressed in very specific ways, because it refers to staff, their presence, and management, all three fit together.
Thank you. So with regards to unplanned absences, what we're referring to there is on a given shift, we have dedicated number of resources. Prior to that shift starting, we may get a call to say staff A, for example, is not coming in today, so cancelling that shift due to personal reasons. That sometimes may be sickness. We have had instances where an example would be around childcare issues that's arisen. So those, I would have to say, are sometimes the two main issues, or mainly around childcare. Again, I think what I've mentioned previously is when we are in a situation like that, and again, working closely with HealthWatch and getting that timely feedback from HealthWatch in terms of what are the issues, we have put in place some of these measures, which I will outline. So on a daily basis, we have our nurse bank that works closely with us. They attend our unit safety huddle. And at that point in time is where we will discuss what are the gaps within our services. We will then also closely look at the acuity levels across the services and the staffing levels that we have. We will then redeploy staff to cover the gaps that we have across the services. And temporary staffing will also work with us to find additional staffing as well. In terms of leadership, across the unit, we have matrons that are dedicated and working closely with our wards, and that's a senior nurse present pretty much on the floor, so physically there, supporting and leading. But in addition to that, we also have the ward managers, so they are responsible for that ward, and then there's also a shift lead. So we have a very defined leadership structure that is in place. If there are times that there are gaps within that services, again, that is escalated up to the matrons or to myself. And then we will regroup as a team. And this is what I referenced earlier around the safety huddles that occurs across the unit. And those huddles don't just happen in the morning. They can happen at any given time during a 24 period. If the acuity levels, for example, changes and we need to look at the risks that we're managing, again, to look at how best we can move resources or reprioritize the tasks that are down on that given day to release resources to be on the floor with our patients. So in terms of our vacancies, again, I think I've mentioned as well, we've made significant improvement around that through the various engagement events that we've had. And that's something we're really proud of, but that's taking a lot of time and it's been a lot of hard work. And I think another thing we're very proud of is that we've not sat on the feedback that we've been given, because it's important that we respond in a timely manner to our patients. We have regular weekly meetings that occur on the wards, and it's important that we keep our patients informed. It's also important that we continue to get that feedback, even post the work that HealthWatch has done in terms of how things are working on the ground for us. So those are some of the challenges that we still face in terms of unplanned absences. We also look very closely in terms of our roster management. So ideally a roster which reflects over a given period, i.e. a month, for example, 4 weeks, or staffing levels on a given ward, should be completed and in place 6 weeks in advance. And that includes us looking at annual leave, for example, which is an example of planned leave, which will then give us sufficient time to put measures in place and resources in place to ensure that that's covered. So there's a lot of work that happens well in advance, but also continuously on a daily basis, shift by shift, to ensure that our units have the safe staffing levels that we require.
Thank you very much, Crystal, for responding to Jim's questions. And yes, as you say, Jim, I think it's important as well to reflect on those areas that are of concern and how they're being addressed. So, and how they're being developed and improved. Thank you very much. Lisa, I would like to invite you, please, to ask a question or comment, and then I would like to invite Joe. Thank you very much.
Thanks, Chair. Thank you, Crystal, and thank you, HealthWatch, for the report, and Crystal for going through in such detail. That's really helpful. And just to say, applaud the Trust on being so transparent and inviting HealthWatch in the first place to have a look at what's going on. And so I think that's quite a brave thing to do, a necessary thing to do, but quite a brave thing to do. A couple of comments and questions. So as has been said, it's positive in parts, and it's not a great read in other parts. And what I'm interested in terms of the findings is how will the improvement plan be monitored, and who will do this, and are you thinking about having a suitably technically qualified person to come in and regularly offer an external audit, a regular external audit program? I'm not talking about CQC, but an auditor to come in and check that those improvements have been made, as that seems to me something important. And I agree with what Jim said, that some of these changes are just not going to be made overnight. Inevitably, when organisations are inspected, and we're inspected ourselves and some of our units, it takes time to make sure that the improvements have been put in place. The other thing I was unclear on was how were patients chosen to be interviewed? Because by the very nature of, if someone's on a ward, they must be acutely unwell. So I was just interested really how people were chosen, and also the skill level. And I don't mean this in any way meant to be disrespectful, but the skill level of people undertaking those interviews as well, because I think it was paragraph 6.3 in the report. I didn't fully understand that paragraph, I have to be honest, and maybe it was just the way that it was written, if I'm picky, but because it seemed to suggest that the volunteers were upset by what they heard, and then it also talked about the fact that the staff were upset about what they heard. So I'm not saying that that there's anything wrong in that at all, that actually that shows that you know, people are human and compassionate. It's nothing wrong in that. But it just struck me that certainly the nursing staff would have undergone, what, 3-4 years training. And I was just a bit surprised, really. Maybe it's the way it's worded, that paragraph. Anyway, I don't want to get stuck on that, but that's just something to have a think about. So my two questions are the findings, how will the improvement plan be monitored, and who will do this, and what are you thinking about as a trust, as a unit, in terms of looking at an external audit program to look at those improvements and how well they're being implemented. And I suppose a simpler question is how were the patients chosen? And I just was struggling with, if someone's acutely unwell, how appropriate it was to have a conversation. I don't know, that was just something I was pondering on, really. Okay, thank you.
Lisa, could I take the first part of your question?
Yeah.
The improvement plan is quite dynamic, and so there is a monthly meeting where Colleen meets with the heads of service and matrons to oversee what new information is coming up, you know, what actions have been taken, what still needs to be done. It is a journey that we're still on. And actually, thinking about what you just said about an external auditor, it sounds really quite an interesting idea. We have RSM Tenant who audit different parts of aspects of pathways and services in the trust. So it could be something that we could add to the internal audit that already goes on. And that's quite a robust process, which is overseen by the by members of the board. So I think that's a really good idea to take back. Just to say, we were doing this as a kind of 1-year piece of work, but it's been so valuable that we are continuing for another year and looking maybe to expand. And certainly the board heard a presentation on this work a couple of weeks ago and suggested expansion into other parts of the trust. So that's something that's already been thought about. I just wonder around your second question, how patients are chosen to be interviewed given the acuity of individuals at any given time. I don't know Carleen or Crystal. I don't know Carleen.
Yeah. I'll come in on that one.
Yeah.
They aren't chosen. We go into the wards and we speak to anyone that would like to talk to us. There are some people who at that time, they may have only recently been admitted and they don't have the capacity to talk to us. But even those patients who maybe we might not be able to go through a questionnaire with them, we'll sit and have a conversation with them, and we'll still be able to gather little bits of feedback from them. In regards to the staff and the experts by experience were upset. So the staff was one of my staff members, and the experts by experience are experts by experience that were upset. And this is quite often just because they have their own mental health issues. And so it can be triggering for them to hear certain situations in the ward that might trigger their own mental health. And they've managed it all really well in that they've always taken a step back whenever they've needed to, and they've noticed that they need to take some time off from the project.
Yeah, thanks. I think it's just, thanks, Colleen, on that. I think it's just the way it's written, because it's a bit unclear whether, one writes reports and often don't make things as clear as I could do. I couldn't work out whether it was the staff on the unit or which, who they were. And I'm still a bit, I don't know what I think. So I'm thinking out loud, and not a good idea, a scrutiny committee, really. But I'm just kind of wondering how you judge who's fit or not to interview. And that I just have to contemplate, because I can't quite grasp that one. Okay, thank you.
Thank you, Lisa, for your questions. and comments. I will also I would like to invite please Joe, Beatty, and afterwards Councillor Coleman. Thank you very much.
Thanks, Councillor Perez, and thanks for a really interesting report. And I agree with Lisa. I think it's a really brave report, and quite often my experience of co-production, of engagement with residents is you're always hoping that they're going to tell you how great you're doing, and quite often they don't. And I can see Jim smiling there, because that's what it's really all about. And just a couple of things that I wanted to mention. I think the first is just about the word dignity. And I think that obviously anyone that's in a situation where their mental health is pretty serious, they're in a hospital, the issue of dignity is a really tricky area, isn't it? Because many will feel they've had much of they've had their freedom taken away from them, and they've had a lot of their choice and control taken away from them. So I think it's just important to recognise that, and just to kind of cast that lens on maybe making judgments about what is dignified and what's not dignified. And that leads me on to another piece, which I think is a real opportunity. And I think it's the work that we're working with the Trust at the moment, and through the mental health campaign that Helen chairs, to secure a lead for co-production. And I think there's obviously a lot of work happening in and around the Trust, linking in with Health Watch. There's almost a little universe of potential co-production opportunities. And I think on the experts by experience, Carleen, I think you're spot on there. Of course, it's brilliant to involve people, have experience of systems, services, support, because they've got that lived experience, but it always comes with so many risks, doesn't it? And I think that if we look at that work on a bit more of a grander scale, and look at how that co-production infrastructure can better support conversations with residents, because all good co-production starts there, doesn't it? Conversations with residents and building a little network of experts by experience, and looking at what their development needs are, as Lisa said, making sure that we're supporting them across the integrated system. I think we could do something really quite exciting. It's not an easy area. That's why I think it's a really brave and courageous report. It's not all about flowers, but wouldn't it be fantastic if together we could start getting many, many more positive pieces of feedback about how we collectively support residents with a whole array of mental health issues, not all of them informing a hospital stay, but some of them about people proactively being in their community. So yeah, just wanted to add the piece about choice and control. It's not really for an answer, but definitely some opportunities going forward, I think. Thank you, Chair.
Thank you very much, Joe. It's interesting as well what you're saying in terms of potential work and co-production, which definitely, as we've said before, it's very important for the administration and areas as well that we could incorporate in. Helen?
Yeah, no, just to agree with Joe, and it'll be great to connect this work with Health Watch with the co-production piece that we're just kind of launching in mental health with Joe and her team. So I think that's the intention.
Thank you very much, Helen. I've got Councillor Coleman, and then I would like to invite Nick Hipkins, please. So, Councillor Coleman.
Yes, thank you. I think everyone said a lot of what needs to be said. It was a very interesting report. It was nice at the end to read some of the fantastic comments that users made. But that came at the end of what was really quite a bleak report, I think, in many places. And I'm not convinced, I have to say, and perhaps I'm able to say things a bit more straightforwardly, but I'm not convinced that, from what I've heard tonight, the Trust really has owned the comments made. I'd like to have heard a little bit of surprise that we were shocked to hear this, we were shocked to hear that, we didn't know that was the case, because that's what the report says. And everything I've heard tonight was sort of, oh yes, we're addressing all that, that's being sorted out. So I'm not entirely relaxed, having read what some of the things that in the report. that the trust has sort of fully owned the challenges that the report presents. And I would like to endorse Lisa Redfern's suggestion that there should be, in 6 months, let's say, a suitable period of time, an independent assessment, not by Healthwatch, because they've been involved in the first piece of work, but a separate piece of work done by someone separately, an independent assessment to check on whether these improvements have taken place. And I have no doubt from what I've heard tonight I won't say that. I think there needs to be an independent check of whether the improvements have taken place. And can I have a confirmation that that's something that you will consider, please?
Thank you, Councillor Coleman. And yes, most definitely, we will consider that. I presume, I don't want to second guess what Chris is going to say, but over to you, Chris.
You successfully second guessed what I was about to say, Helen. I guess I completely support the suggestion that Councillor Coleman and Lisa have made around. So first of all, to say, I think that we really are pleased with this piece of work. I suppose there's a couple of things that when this was presented to the board, we wanted to emphasise is that we don't see this as outsourcing our responsibility to listen to our service users. This is to supplement our duty to listen to everything that our service users say all the time. And actually, by providing the partnership work that we have with Healthwatch here, provide someone who's not wearing a trust badge to have a conversation. And actually, the work with experts by experience and peers provides perhaps a different way to reach the organisation with the feedback that we're hearing. The question about whether we were surprised or not is an interesting and fair one. What I suppose is fair to say to that is that we were disappointed by some of the feedback that we received within the report. But I really wanted to emphasize that this is the report really of 4 quarters, well, 3, I think, of quarters worth of work so far. So some of the changes that have been made have been iterative during the course of that year. And I'm positive about the work that Crystal and colleagues are doing on the inpatient settings to address this. The context in which we're working is one, of course, where there have been a number of really shocking revelations about inpatient mental health in the public domain, including the Panorama documentary before Christmas. And as an organisation, we're really committed to ensuring that that kind of experience is not experienced by our patients. And that, as a board member, I think that's something that we are having a number of initiatives to make sure that that is not something that would be replicated in our boroughs. And finally, just to answer the question of would we get the independent auditors in, I think it's a really good suggestion. And I think we've already signed off the audit plan for the current financial year. And I certainly think it would be my commitment to the committee that I would add it to the audit plan for the subsequent financial year, which would be a good opportunity for us to review the full 2 years worth of improvement that should fall from this partnership work.
Thank you very much, Dr. Hilton. And just to confirm as well, following that question and that suggestion from Councillor Coleman, there's going to be an independent assessment to.
Yeah. So just to be clear, I'm very happy to put this forward to the audit committee. It's not entirely my decision, but I'm sure they would welcome the recommendation that we use the trust's internal auditors, and that's an independent company called RSM. That we engage to undertake audit of this nature on our behalf to look at exactly the question that you're asking us about whether the changes that have been recommended have been made and sustained.
Christopher, if I may just ask about that point, if these are people who already audit you, you would have thought that the issues that were raised by Healthwatch, forgive me if I'm being ignorant about how I approach this, but you would have thought that the issues raised by Healthwatch would have already been raised by your independent auditors and therefore would already have been addressed. So might I suggest that somebody else comes in and does the job?
I think that might be around the way that the internal audit process works, because they work on specific programs of inquiry that have been recommended to them that are driven up by the trust's internal risk register system. So they wouldn't have looked at this specific area, to my knowledge, they wouldn't have looked at this specific area previously. And that's the audit program that the audit committee oversees.
And they're a retained audit body?
Yes, so it's an independent company that undertake scrutiny on behalf of the organisation directed by the Trust's Audit Committee. And their programme, they happen to be RSM at the moment. They're contracted with us is usually for 2 to 3 years at a time.
Right. Okay. So there's not a danger. And sometimes when I'm thinking of different sort of audit, obviously I'm thinking of financial audits by companies. You can have auditors can be a little bit soft sometimes, much to the disbenefit of shareholders, on the comments that they make and the way that they make the audits and publish the audits. And I was just hoping that because these auditors, because they wouldn't be worried about losing a contract over time with you, would also, one hopes, not want to pull their punches. And that's why I was suggesting that you bring somebody else new who hasn't been used for a one-off job from outside.
I understand the suggestion. I think the norm. I'm learning about the trust audit process as I'm 18 months into my role, but I'm certainly happy to discuss it with colleagues. And the point is, I definitely recommend further scrutiny of this piece of work to evidence that the work has been implemented and sustained.
Thank you.
Thank you, Christopher. I think as a committee, we would welcome in the future an update on what has happened.
We're
Maybe
very
also
happy to come back with further report of this nature with the Health Watch colleagues if they're willing to come again, and any findings that a separate audit would reveal.
Thank you very much. Okay, I would now like to invite Dr. Nick Hipkins, please.
Yeah, thank you very much. Firstly, I just wanted to say what a really interesting 2.5 hours this has been in terms of I'm a new member into Hammersmith and Fulham. I'm the clinical lead working for the crisis team in Hammersmith and Fulham. We also have oversight into the inpatient unit. And one of the things that is really reassuring to hear is the level of sense and insight that you bring and the questions that you're asking, which I think are very similar to the questions we're asking ourselves sort of internally. And so thank you. It's just a really interesting and fruitful experience to come. What I would be really interested in coming back if appropriate and sort of to feeding back some of this work. And I also, I suppose, just wanted to reassure that I suppose a big part of where we want to, we're not trying to dress things up. We know we're not perfect. We know there are lots of things that we need to improve. And I suppose there's an element of, I agree, I think we need to own that perhaps louder. And I suppose part of the main bit of work moving forward is about that value set that does take time, and that sort of humanity and dignity that we need to bring forward and to be central at all of the pieces of care that we provide to Hammersmith and Fulham residents. So all the patients we look after, I think, has to be a central tenet of everything we move forward. And so thank you very much for allowing me to be here. Incredibly interesting. I'd love to come back if that's okay.
Thank you very much. It's good to have you here, and of course, very welcome. Join us in future meetings as well. I wanted to ask a question in relation to the monitoring as well of the feedback. I know, of course, from the reports and the detailed information, the people that have been, the residents that have been, the patients that have been approached as part of this consultation. And I'm wondering if there's a possibility, maybe not, but of going back to some of those patients. I'm not sure if that's possible or not, in terms of understanding a little bit more how they feel about some of those aspects that they have raised as areas of concern after they have voiced and expressed maybe reservations about some aspects of the service. To see, I mean, just to monitor as well, and for them to know that their voices are heard and that their feedback is being taken into account in terms of improving services and decision making.
Is that for me or Colleen?
I mean, the feedback that we share, I do know that they're being, because I've overheard a couple of the community meetings, some of the changes that we've implemented, I've heard them being shared at the community meetings, that these have taken place because of feedback that they've given.
Can I check, Councillor Perez, that's what you mean, that those people who've been spoken to as part of the project do get that feedback as to what's been shared and what's being changed.
Yes, and if they've got some suggestions or areas for development, that you've heard of those recommendations. And these are this informed decision making, this inform improvement of some of the services that are not doing so well.
Could I just make a comment? I think we've definitely got a kind of you said we did process on the wards for the populations. That is a kind of more accessible version of the report that you've described, and there's more work ongoing. But I wonder if Councillor Perez is also asking us to consider in our regular review meetings about the project as it goes forward, whether there is any mechanism to follow up with specific individuals who might have given one bit of feedback to see whether, were they to be readmitted, for instance, as their own control, they feel that things have changed. I don't know whether we've got the facility to do that currently, but it's certainly something we could discuss in our regular planning meetings.
Yeah, agree.
I think that would be interesting because it's powerful, and I think it's empowering as well for the individuals that have been consulted and for the ones that are giving that feedback to know that they're being listened to.
Just quickly ask something on that. Doesn't that pose a problem with confidentiality?
That's why I'm not sure we can do it. But
yeah, I think you might need to check on that first, because I can see there could be an argument saying that you're breaching confidentiality.
The idea that I had, and I'm not as close as Carleen and Crystal to the project, but there may be a question that could be asked: would you be happy for us to contact you again? And if or something of that nature that would allow us to follow through. But mindful that we've got probably another year's worth of conversations of this nature to have, I think it's certainly something we can explore and test with individuals about whether they would find it acceptable.
Yes, I think asking for their consent, asking for their agreement, asking as well for their information to be used as part of the improvement plan. And if there's an agreement under that consent, then maybe that's something that could be explored, as long, of course, that you're not breaching any confidentiality agreement, and also making them aware that they have a right to withdraw that consent at any stage of the process, no? Okay, are there any further questions on this item? Okay, thank you very much. We now need to move on to the next agenda item, please, which is the work program. So for members of the committee, please. So we're now moving on to the work program. And just to say thank you very much to the members of Health Watch as well that have been covering the previous agenda item. It's as you've heard this evening, there are many aspects of this report that are welcome, and there are also some recommendations also going forward. But thank you very much for your time this evening. To Crystal, to Carleen, to Helen, Dr. Hilton as well. Thank you very much. Okay, Linda, you've got your hand up.
Yeah, I'm not sure if David was looking to share the work programme, but excuse me, met with David and Joe to look at the work programme earlier. There's a number of things on it. It's quite a long list. And I do wonder, I think it's been really helpful tonight to have sort of a cluster of theme things. I mean, it might not feel it for Chris and Helen and colleagues, but the fact that we've focused in on mental health, I think, has been really helpful. Perhaps if we focus in on quality or safety or standards or whatever, just a suggestion, if I may, Chair, that perhaps if myself, David, and possibly Joe could take away this very long list we've got now of the work programme and perhaps see if we can cluster it into certain items, possibly something around quality assurance, because that, it's not just about West London Mental Health Trust, although it has been tonight. Thank you, Christopher. But it is about quality of health and social care in its entirety, safety, We might want to look at service developments or service changes as well in that. Just wanted to sort of put that forward to members if that was helpful.
Thank you, Linda. I think that's a good suggestion, but I would also want to suggest as part of that plan that we also take into account some requests that have been made in the past committees. And I know, for example, that Councillor Rosenberg on 2 committees has requested that long COVID is discussed. So please, if this can also take priority, that would be great. And I see Councillor Lloyd Harris has got her hand up as well. You have also made some suggestions.
No, actually, not specifically, because as far as I'm aware, this PAC is for the members of the councillors and others on it. And surely it should be up to us to decide what we feel are issues that may not have come for reports or anything for some time, like we do for dentistry. We've had huge gaps over a period of time. So I would like to suggest that we circulate a list of what is out there and that the members is relevant going forward, because some things get left off. And I'm not suggesting it's deliberate, it's just there are so many things. If you want to put them into groupings, fabulous. But I think it is definitely up to us to make the decision as to what we discuss.
I note your comment. Thank you very much.
Thank you very much.
Jim?
The suggestion just made makes sense to me, actually, because the number of topics we might pick is not quite infinite, but it's very, very long. I mean, I can think of things, for example, that sometime in the next few months, there should be a set of recommendations on end-of-life palliative care. It's at least 6 months behind publication. And there's a question of GP services, which I do know exercise the public a great deal. But I think a circulation of topics to actually look at what topics might be worth talking about, and they could be fitted under Linda's heading about quality and so forth, I think without too much difficulty, well, should move us on.
Thank you very much, Jim. That's noted as well. Councillor Rosenberg.
Yes, hello. Yes, to get back to the long COVID, I was planning to have a session with a journalist who's been doing quite a lot of research, but she has been extremely ill with long COVID, so we haven't as yet managed to have a proper meeting and discussion. So perhaps we could sort of put it on hold until the next meeting, and I'll send in a draft suggestion for the discussion.
Thank you very much. As noted, Councillor Rosenberg. So, Linda, you have made that kind offer of revisiting that very long list of items that has been suggested, and we've also heard from members of the PAC that they wish to have, of course, their the input in terms of deciding what it comes to committee. Can we come with a plan, please? Come up with a plan.
Yeah, absolutely. I'll work with Joe and a couple of other people to make that happen. And obviously, Councillor Lloyd Harris, it's within your gift to decide what is and isn't on that list.
And the outcome of that list, if you could please circulate it to all members, that would be appreciated. Thank you very much.
Sure.
Brilliant. Okay, thank you very much. So I'm ready then to move on to the next agenda item, which is dates of future meetings. So the next date that we have is for April the 26th, followed by the 19th of July and the 15th of November. This is for this current year. Everybody happy with those dates? And before we finish, I wanted to note and to say and to send a massive thank you to Bathsheba Mo. She has been supporting the committee for a few years. She has done wonderful work and her input has been very valuable. I've started to chair this PAC. I started last year, and her support was great. So I wanted to know that. Well, sadly, she's taken another responsibility, and I'm very happy for her in terms of the new role that she has within the council. And I'm welcoming as well David for his support as well going forward. I wanted to know that, please. Great.
It just gives us a heads up as what's happening to Bathsheba. I have not a clue. It's Councillor Lloyd Harris again.
Do you want me to come in? Do you want me to come in, Chair,
yes,
or
please.
you have?
Yes, please.
Yeah, she's just on secondment to the cost of living policy work. So she's just helping out with that for the moment, Councillor. Just as so through our get ahead opportunities. So yeah, so
we're losing our expertise.
Well, I think that to be honest, Bathsheba's been working behind the scenes with David and advising him regarding this meeting. So she's still with us. She's still there. Yeah.
Oh, that's good. Hate to lose her.
Yeah.
No, she's still part of the council, and now we have David with us. So thank you very much, David. I know he's with us this evening. Thank you as well for supporting us. Lisa, I was thinking, gosh, I hope this is not Lisa's last participation with the committee. So I'm glad to hear that you will be with us next month.
Thank you. Yeah, you stuck with me for one more meeting, sadly. So
fantastic. That's very good. Okay. Great. Okay, well, thank you all for your time this evening and for your questions and your input and your recommendations and feedback. And thank you all as well to all our guest speakers this evening. We appreciate your contributions. Finally, thank you as well for agreeing to do it online. I know it was a last-minute decision, but it had to be done. But thank you.
You're better soon.
Thanks to you as well. And let's hope you're better soon.
Yes.
You already chaired well. So thanks.
Very impressive. Yeah.
Yes.
Thank you very much.
Inspirational.
Oh, thank you.